Hello everyone, this is Thomas Weimbs. I'm the president of Santa Barbara Nutrients. I had the pleasure to sit down with Markus Säemann, a professor of nephrology from Vienna in Austria. Dr. Säemann is also the chief of the nephrology department at a large hospital there in Vienna, and also the president of the Austrian Society of Nephrology. As you'll see in the interview, Professor Säemann's personal experience with type 1 diabetes led him to discover ketogenic metabolic therapies for himself, and this also changed the way he practices medicine now with his patients. So if you're wondering what happens to people with chronic kidney disease if you treat them with ketogenic metabolic therapy, watch this video. Enjoy. All right. Hello, everyone. Thomas Weimbs here with our guest, Markus Säemann. Really happy to have you, Markus. Great to see you.
Thank you.
Dr. Säemann is in Austria, in Vienna. And I thought maybe first we'll try to figure out who is Markus Säemann. Obviously you're a nephrologist, a medical doctor, and I wonder how your journey was to get to where you are right now. You went to medical school and so on, but how did this all happen, and why kidneys and so on?
Yeah. Thank you, Thomas, for the invitation. To give a short overview of my biography. So maybe the initiation why I went to medical school was just as a prelude. I'm since 1982 a type 1 diabetic, and therefore I was always interested in somehow in how the organism works, and this brought me to medicine. And initially I wanted to become a diabetologist. And in the beginning of the 90s, there was a very optimistic wave that soon type 1 diabetes will be cured with islet cell transplantation. So there's only one little step. This is immune tolerance. So I thought I will join this force as an enthusiastic, overconfident student. And then I went to a transplant immunology lab at the Institute of Immunology in Vienna. And this was the journey into everything what has to do with tolerance, so to say. So, and I was then there 8 years. So I did my PhD there, and therefore my basic education is an immunologist. And there was a strong linkage to the nephrology department because of all the kidney transplant patients. And since diabetes affects the kidney, it was always in my head somehow. Then I knew I will not become a surgeon, so I started my fellowship in internal medicine and focusing on nephrology in the Medical University of Vienna at the General Hospital. And there we did a lot of also translational and clinical research in my lab. So we focused on a lot of immunosuppression. We found out in a multi-year project what role has mTOR in innate immunity. And then I thought I will come back to diabetes, and we focused on post-transplant diabetes, and we did a lot of clinical trials in this arena. And after some decades, then I became then head in a large nephrology unit in the formerly called Wilhelminenhospital, now Clinic Otterkring in Vienna, and we care for a lot of nephrology, including dialysis patients. And then my circle somehow closed because I came back to treating diabetes, so to say, at the front. And so 6 years ago, there was a lot of enthusiasm with bringing a low carb diet forms into the clinic. There were these fantastic papers of Sarah Hallberg and whole Bertha Health Group, and I started treating patients with chronic kidney disease which were excluded in all these trials, and we had some fantastic results. And then we started clinical trials, and they are still ongoing in patients even with advanced chronic kidney disease. So in short, this is my story.
Wow, yes, that was great. That's the entire story already. Well, let's dig into a couple of things. So just to recap, I found that very interesting. So first, you realized I think you said like 1980, early 80s or so, that you have type 1 diabetes, which is of course a scary thing to learn as a young person. And that made you interested in medical school, going to medical school. So that's interesting. And you got your a PhD first before getting an MD, or how does it work in Austria?
Yeah, this was now it's everything is standardized and normalized in, so to say, the Western world. And at this time in the 90s, it was, so to say, synchronized simultaneously. So
Okay,
you get the MD and the PhD.
got it. Okay. And you did a lot of research, probably like basic immunology research and so on. So that's where
Yeah,
a lot of your
yeah,
training comes from. Um, and that
yes,
probably shaped, everything you do today, all that background.
yeah.
And then, of course, you mentioned, a few years ago, sort of low carb came on your radar, which I always find baffling that, you know, before recent, this was not really on the radar of anyone, right? So, although, if you go back 100 years, of course, you would, anyone with diabetes, people understood, you gotta cut out the carbs for those folks, otherwise, they're in big, big trouble. Um,
Mhm.
so why did all this get forgotten? And so
Yeah.
I'm teaching physiology and things like that. So from just like a basic physiology point of view, you would think, of course, obviously someone with actually both type 1 and type 2 diabetes, they should limit their carbohydrate intake as much as possible, and sugar, of course, should be completely out. And all this got forgotten, strangely enough, even though people still learn physiology. Everybody should actually know this. What's the explanation for why people have been actually almost treated with high carb diets, and just the idea is, oh, just
Mhm.
take as much insulin as you need, and eat whatever you want, almost. That sounds like it.
Yeah, that's a very interesting and fascinating question, and one should dive into that also maybe by writing a book about the whole history. Maybe I'm not looking like a museum, but I'm a wandering museum of diabetes, because in the early 80s, um, it was hard to imagine how the type 1 patients were treated and what was the dogma at this time. And at this time, the dogma was, and was deeply rooted in medical school for then many years on, was that carbohydrates are simply essential for the brain, finally, and you have to eat at least 50 to 55% of carbohydrates, and according to that, you have to manage the insulin amount. So you can't go lower, otherwise you will get severe problems. So first with your brain, and on the long run, you will damage your vessels, your heart, and if you have a too high degree of fat or proteins. And this was rooted, and I have to blame myself somehow also, not to be like every scientist should be, to simply to question and to falsify, so to say, the theories and the dogmas. So when we made our post-transplant diabetes studies, we were again focused around the concept to bringing early after transplant the blood sugar down, and normalize it as with any means. And we did even an FDA-sponsored trial. We were in Austria, and we got an NIH sponsoring. So it was a rare exception that we got an NIH sponsorship, and we did it with certain kinds of insulin that we used. And it was maybe more than 10 years that we did it on a multi-center level also. And even at this time, there was not a single thinking about the fact that nutrition can be something like a nutritional therapy and makes maybe 90% of the success, which I always now tell the patients. When at this time you focused on the glucose metabolism, and you had some vague dogmas about diet in your mind, and it was never questioned whether it could be feasible that you really can go low, and even lower, down to 20-30 grams per day. And it was a little bit on the radar from the far side, Dr. Bernstein, New York, and you thought, okay, this is an obscure kind of religion, what they are doing with 20-30 grams per day, and whatever they are doing, there's no solid evidence, and so let's do our stuff. And I think also our kind of science is somehow, of course, it's dominated by evidence-based medicine, which is by and large grounded also on giving some kind of drug therapy. This doesn't exclude that drugs are necessary. It could be necessary, but it's maybe a little bit too high prioritized. And due to the lack of studies at this time point, 2010, 11, 12, 13, and no large prospective trials, it was some kind as a miracle. So 2016, 17, because I started it for myself, and then I saw, and therefore I have to thank the new times, with social media, you can connect with several people all around the world, and you instantly see large effects. And then at this time you had also these larger trials, and then I had to rediscover physiology and cellular metabolism, what is really going on, where are we heading, where are the unanswered questions. And there were so many unanswered questions that my scientific soul was somehow again stimulated. And so I embraced this whole concept, because bringing it to practice, seeing success, and even have a myriad of unanswered questions. So this was like paradise for me. So seeing it for myself, seeing it to my patients, and having a big horizon with regard to scientific discovery.
Great. And I totally agree. Somebody should write a book about the history of what went wrong, and for all these years, and that would be actually really interesting. So how did you first come upon it? I mean, so you started experimenting with low carb on your own, but somebody must have kickstarted it, or some kind of
Yeah,
experience, or what happened?
yeah, yeah. So this is not a scientific thing that I can tell you, but then it went on scientifically because it was by a book from Tim Ferriss, and he interviewed a lot of guys there. And there is this one guy who has this health podcast. How is his name? He did it on his own, and he was somehow credible. And I thought, what? He does triathlon and dozens of kilometers swimming and so on and he admitted he was on keto. I thought, how is this possible? Then I searched, and then boom, I found tons of experiences and the first studies, and also the studies that were done by the two guys who are on the scientific board at Wörter Health, and they have long experience, and they published a lot with military personnel and all this kind of stuff, and had hundreds of papers. And this was the reason why I said make a Kickstarter and just do it for myself. Yeah.
Wow. So you just tried it out.
Sorry, now I remember Peter Attia is the guy.
Oh yeah, of course. Okay. Well, that's actually. I think he's also a big YouTuber, and that's.
Yes.
And I totally agree. Actually, the most I've learned about keto approaches, I got from YouTube actually. Because if you open a textbook, a medical textbook, it's completely useless. There's nothing in it.
Yes.
Even nutrition textbooks, they're. I have a whole stack of nutrition textbooks, college level,
Yeah.
graduate level textbooks, and they always say,
Yeah. And
no, you're gonna kill your
and-
patient. You can't do it.
yeah. And this is maybe also an important point that it is not taught. I think all over the world, the nutrition for medical students. So we never don't see it in any curriculum that you give it to the nutritionist, this stuff, and you don't care much. And when I look deeper, talking with my colleagues, whether they are cardiologists, surgeons, or what else, nobody has a deep understanding of what is occurring at the metabolic level, on the biochemical level, or even has some clue about all these nutrition studies. So there is really an absence of any kind of deeper knowledge, and this starts at the medical curricula.
Right. Yeah. I hear this all the time, and I'm teaching pre-med students a lot. Hundreds and hundreds of them, and you're absolutely right. There's no nutrition class at my university, so those
Hmm.
folks go into medical school knowing nothing about nutrition, and medical schools also don't have
Yeah,
any nutrition classes in the US. So yeah, so it shouldn't be surprising, I guess. Yeah,
yeah.
so that's interesting. And so you just did it. Did you go like full on keto immediately, or how quickly did you feel any effects, and probably measured your blood glucose, I'm assuming.
Yeah, I did this just do it approach. So I started immediately going down to 20, 30 grams, and then started just looking on observing as good as it as possible in my own body what occurs. So first on the glucose, blood glucose variations and the stability, the need of insulin, how it alters sleep perception, concentration, and all this kind of stuff. What's going on with the blood pressure, and it immediately worked. So I had no kind of transition phase or flu phase, and I tried then to adapt it according to my lifestyle. So I play every Friday, Sunday tennis. How does this work with a mixture of aerobic, anaerobic exercise? And so I pushed through, so to say, for the next months, and then I was enthusiastic about this whole thing, and immediately somehow transferred it to my patients, and it similarly worked, and
Right.
it became more and more proactive and even aggressive, and this is where we I never saw such a kind of good feedback that you have as a medical doctor working in internal medicine, because you have a lot of patients, especially in nephrology, who are rather older, have a lot of comorbidities, and you don't get such a feedback if you prescribe a drug and then maybe the blood pressure is better, what else. But then they come back and do not need any more insulin, for example, or the kidney function improves, what I never saw before. And most importantly, the patients say, whoa, I had to inject 30 years insulin. I don't have to take my sugar with me because of fear of hypoglycemia, and I feel much better. And the relatives also tell that. Or they lose a lot of weight. And immediately you start this art of deprescribing. So get rid of diuretics and antihypertensives. And so and I thought, what's going on now? Am I the stupid guy in the whole arena here, going to the traditional congresses, or what's going on here? And therefore I tried to, and also my colleagues saw that working for decades with their patients on the standards therapy, they saw also the success, and I tried to convince them that we have to study that to gain more evidence, and that we can also publish that. Yeah.
Right. Interesting. And by that time, of course, I mean, all your patients are, I'm assuming, kidney patients, right? So you're seeing them probably because most of them have actually type 2 diabetes, I would assume, and diabetic nephropathy, which is, in a sense, actually caused, by high glucose levels, maybe potentially somewhat directly, who knows? So in so you used a low carb, maybe even keto approach on those folks, and saw improvement not only in their glucose control, but also you said in their kidney function. Can you tell us
Mhm.
more about that? What the results on kidney function were?
Yeah, I mean the point is that most of the patients with diabetes, plus minus overweight, and having CKD, chronic kidney disease, when we would look now at present times at the kidney with a biopsy, it's a mixture of hypertension, arteriosclerosis, genuine diabetic nephropathy. So half of them even don't have albuminuria. So this is the consequence of, I think, our lifestyle with having metabolic syndrome, overweight, insulin resistance, and all this kind of stuff. And there were two things that were interesting to know. So first, does it practically work when a patient is kicked out of its normal habit, so to say? And the second thing is what's going on with the co-medications that they have, the diuretics, the antihypertensives, and this new compound class, this SGLT2 inhibitors, which made a quantum step in delaying kidney disease progression. So does this work together, so to say? And the fundamental thing was that it is possible, and you see quickly results. So first from is it possible to adapt such a lifestyle? I would rather say it's a lifestyle rather than a diet. And yes, it is possible. And second, is it possible to combine with all these kind of drugs? Yes, it is perfectly possible. And the chance that you get rid of significantly number of these drugs is very high. So the best patients started with, 10, 12 medications or pills, and now have only one or two. So, and this boils then down to the philosophy of what should we give our patients, which kind of medications. And so I think a whole kind of new paradigm emerged, grounding of nutritional lifestyle therapy, and then only give the patient the drug has to fulfill three criteria in my mind. So first you substitute something which is necessary for living, so a thyroid hormone or insulin, like for me, if I don't have it. Second, you reduce or you increase the quality of life, such as painkillers or a diuretic if you are overloaded with fluids. And third, does it really prolong life? Any other kind of medication the patient shouldn't have, in my mind. And if you go stringently with these principles, together with this kind of nutritional therapy, within the success rate is extremely high for the patients, both in quality of life and also health and lifespan.
That's amazing. And so I guess prior to that point, I would assume most of your chronic kidney disease patients, diabetics and so on, people with hypertension, they were probably on this downward spiral and never really got better with regard to their kidney disease. And would you say this can actually change? They don't have to be on a downward spiral. They can be either stabilized or maybe even actually improve in their kidney function. Have you seen that?
I would claim that we started with this kind of therapy in about 2017. So I cannot tell you decades of experience, but my experience till this time point, we only had, so to say, 2 or 3 principles. Tell the patient she should move more and eat less, which all of us know that it doesn't work more than 2-3 days. And also from a higher point of view, it cannot work. We can go into the detail later. Second, strive to be metabolically, meaning the blood sugar should to be normalized as good as possible. And third, take inhibitors of the renin-angiotensin system, and the blood sugar should be under control. And with this, we only saw a delay in the progression. And you have to treat people of the ordinary normal life. They are, they work a lot, and you can tell them that they should eat less and work harder in the fitness studio or run in as good as possible, and then take care for the blood pressure control as good as possible. So even with these rules, you rather saw as it was, of course, better than the 90s or the 80s, and the downfall of the kidney function in milliliters per minute per year was reduced from about 10 to 12 per year milliliters per minute to 4 to 6. Now we are at a physiological level of about 1 milliliter per minute. So the essence is, the earlier you see such a patient, the better. But even in advanced stages, we saw remarkable stabilizations for a long period of time in these patients.
That's amazing. Great. So what does it take for a patient to actually do it? So you mentioned, previously, of course, every doctor says, do more sports and eat less food and go home and come back in a year or so. And this, of course, never works, but there's no way to fight obesity that way. Um, so does it take, do you need certain tools? Do you use certain tools? Do you use dietitians? How do you make it actually work for people?
Yeah, this was also a learning process, and now I can tell you, so to say, the heuristics, what we have found out. So it normally takes about 1 to 1.5 hours where I can talk, my colleagues can talk with the patient and ideally with his partner or some close relative.
Right.
Because when we come to such things, such as to significantly alter food intake, that's you going into the intimacy of the patient, because it's a very private thing to eat and what to eat. So you cannot simply, as I saw it over decades with real nutritionists, so simply give a handout and show where's phosphate and don't eat, don't eat that. It doesn't work. So you have to show the patient what is his problem really now and what he has to do, like he would drive a car. So give him all the necessary informations, what's going on now, and how to come out, to find a new way of life. And not speaking in medical terms. So you have an HbA1c of 9%, you must come to 6% if you want to have any chance. So there's a lot of psychology in there. And I use a lot of pictures to frame what is on a physiological basis going on, taking a lot of cartoons. And so after either after 20, 30 minutes, the patients immediately get it and ask for themselves. And then they ask back and we have a dialogue, and it takes about 60 to 90 minutes. And then, as you said, very essentialist and the nutritionist. So when they come to the nutritionist, they already have a physiological background. They know what's going on. And the funny thing is, even I have patients who have diabetes since their 80s. And nevertheless, what I tell them is completely new for them. So they had these official teachings and so on, and had dozens of nutritionists. And when I tell them you will go to a nutritionist, they're, of course, I understand them, they react a little bit like allergic. So you have to frame it completely different. You have a way out, you transform yourself somehow, and then the nutritionist will also take 1.5 hours. So in total, you have 2 to 3 hours that you must invest for the success. And I have patients who don't need any more kind of teachings and explanations. They have only the feedback rounds about 1 month thereafter, and then maybe one another after 2 months, and then most of them are, so to say, flying. So then it works. And I give, so to say, a horizon of 3 to 6 months for all of them. And this is our time frame where I make some kind of a promise that 9 of 10 of patients who go to this, when you, as you say, program, that they have all the success that is needed. And in short, what I tell them is, we don't look at the body weight, we don't look at the blood sugar now, we want that you become metabolically healthy, so that the body is now able to burn fat, essentially, and working also in a hybrid, flexible mode, and is not reliant only on this, so to say, not good functioning glucose flux in an ambient, very high insulin environment. We want that you are metabolically healthy, and you need about 1 month to do this on a strict basis, so to say. And then we will monitor you and follow you, and will accordingly manage your co-medications and all other medications. We will see you then. And when I speak with and I look to all the other programs that had success, such as Eric Westman and so, I think all of them do it more or less in a similar way, whether you call it a 4-phase principle or what else. But this is what we do.
Okay, that's great. So that is actually really interesting. So I think, as far as I know, we haven't really published much about this yet, or is there any, in medicine, there are many different types of clinical studies one can do. There's this big randomized controlled trial, which will probably, who knows, never happen. But you can also do just case reports. That's kind of like the first level. How are you spreading the word in some way in that sense, to let all your colleagues know, shout it from the
Yeah,
rooftops somehow?
yeah, yeah. Starting with shouting it from the rooftops, you get, of course, and we got a lot of resistance. So starting it with all the other nutritionists in Vienna. We are more than 2 million people in Vienna, and getting into in a kind of productive conflict also with nutritionists in Austria, telling them what you are telling the kidney patients doesn't have any real very good evidence. So you should be more scientific and all these kind of discussions. So
Right.
when we want to shout it out internationally, yeah, we had started with 2 trials in CKD patients, even advanced CKD patients, with diabetes and with pre-diabetes, and we had, because it did several trials with several drugs and so on, but a trial that relies on nutritional therapy as a basis, I have to admit that I underestimated it. So we were then somehow stopped out by the COVID, because we couldn't anymore recruit the patients. And then my primary investigator, Stefan Scher, who also had a lot of things to do. So we stopped it at this time. So about 2 years were wiped out somehow, and now we regained it. And in the first place, yes, we will do a case series of our patients, and we know this is the lowest quality of evidence, and therefore we aim to have a very solid ground on at least 2,000 patients that will be compared over a 6 months of period, yeah,
Oh, wow.
to fulfill all the scientific criteria.
Yeah, wow, 2000. That would be a pretty large number. That'd be a breakthrough paper, I think.
2000, sorry, not 2000, 2000. 2000,
Oh,
so
2000.
24
Okay,
patients.
okay, okay, right,
Yeah,
right.
2000.
Uh,
I hope that will be the following study
right,
internationally by other colleagues, maybe
right,
including mine. But even 2000 or 3000, if you do it as a
right.
free arm trial, on a nutritional therapy is extremely difficult. Yeah.
Right, yeah.
If you want to do it on solid grounds.
Right,
Yeah.
right, right. But of course, with if the effect size is huge, you don't need that many patients anyway, right? So
Yeah,
a couple
that's true.
dozen should do the trick,
That's true. Yeah,
Absolutely.
yeah. But we have all the problems you encounter. We have many languages spoken in Vienna. So we have also a language barrier. Then we wanted to do it on a digital health platform. Not everybody has a smartphone. So we had always to rescale it somehow. So all our initial guesses were in this respect wrong, because we translated our personal experience. Our personal experience was always doing it with our patients in the hospital on a very intimate basis. So we always saw it in the outpatient setting. We always had time for them, but it's different in a clinical study setting.
Right.
Yeah.
Great, interesting. But that's interesting that you got a lot of pushback from nutritionists, probably other doctors, and I can completely see that happening because, in a sense, let's say a dietitian, nutritionist might have treated patients for a couple of decades the old way, and for them to essentially realize that they might have done more harm than good to their patients all these years, that's not easy, and to
hmm
essentially unlearn everything and learn the opposite almost. So yes, I can completely see how. So how do you find? How do you navigate that? You want to be. You can't just tell people, "Oh, you're wrong." You've always been wrong. You have to be a little diplomatic, and I know you're a really diplomatic guy. I'm much less so, but how do you do it successfully?
Yeah, maybe one thing I had a big luck with our nutritionist, Silvia Lusek, because she does a tremendous job because she's doing all this patient talk with all the patients, and she's reading all the scientific literature, and so you have to have it's a necessary condition, a good nutritionist on your side. Otherwise, you can't manage that. And regarding my strategies is to be positive, simply showing a new way, and don't blaming what has been done, because I for myself have treated type 2 patients according simply to strict guidelines. Yeah, so no matter what, and even if you take 100 units of insulin per day, the blood sugar must be normal, and saying, okay, then you have a little bit overweight, but nevertheless the blood sugar is the highest priority. And this is not anymore the case in my view. And therefore, I was also very excited when the American Diabetes Association 2019, it was a kind of a little revolution when they also recommended to use low carb as a treatment possibility due to the overwhelming scientific data. So I always try in any kind of when we have new therapies, or we have to also be, and I admit that, to be opportunistic. If there is a new way where our patients can benefit, we must throw away the old hypotheses. And therefore, I'm a scholar of my Viennese idol, Sir Charles Popper. He said, yeah, scientific theory is only as long true as you can falsify it. And it will be falsified sooner or later. And therefore you have to use rigorous methods, scientific methods. So you have to have a good hypothesis, stand it there, this theory, and then everybody will throw something against it. And if it's fallen, it's dead. We have to have a new theory. And then we have to admit that with this kind of practice that we had in diabetes and CKD, we didn't make progress.
Right.
So we have to move forward. And I show them what's going on. And if the nutritionists, and maybe this was also a reason why also our nutritionists saw what's going on with the patient at first hand, feeling better, losing weight easily, and not sending them to some gastric bypass surgery, which is in my case is some kind of mutilation strategy.
Right.
But working on the metabolic base, and even if my colleagues see this, it's great. It works fantastic. And then showing them simultaneously, hey, look at the evidence that was done by this fabulous work of the Werther Group, for example, and other works.
Right.
And therefore, it's some kind of obligation that we have to do this now.
Great, excellent. So at least in the US, it's probably a little different. In Austria, you said you spent initially like an hour and an hour or an hour and a half, with each patient to go over everything, explain everything. Oftentimes, doctors in the US, they get about 10 minutes per patient. And then,
Also in Austria.
oh yeah.
Yeah,
So how,
yeah.
practically speaking, how does that ever work? You almost never have an hour and a half. So, most doctors out there, how could they do it? And how could they bill for it, right? So that who pays them for it? If you prescribe a drug, you bill for that. And if you prescribe 10 drugs, you get 10 times the billing opportunity.
Yeah.
But if you spend an hour and a half explaining nutritional principles to a patient, I don't know if any insurance pays anything for that. What has been your experience?
Yeah, this is a very critical question that you ask. We are all in the modern Western medicine world. We have our 10-15 minutes at maximum and also in the outpatient setting. So we have, in our case, we had to find some kind of special program and space and time to say, hey, you are for this program. So we schedule it, because this is a very, very good investment. We have to break it down on this. If you invest only 10 minutes, it will be 10 minutes, 10 minutes, 10 minutes, and we see the downward spiral of the patients. So when I showed it our public insurance group, what we had kicked out as diabetes drugs, hypertensive drugs, they said, whoa, we, of course, we can do a cost-benefit analysis and all this kind of scientific stuff, but if you simply calculate it, you will save so much money. So that this 1.5 hours is negligible. And why do I say 1.5 hours? Because this is what I have found out. It's not possible in half an hour and 20 minutes. Yeah. So on a future prospect to scale it up, we also thought about that. I can imagine other possibilities. So having classes, doing some kind of tele-lecturing. I can imagine that this could be possible. But again, you have to give the patients time. They are not medically experienced. They have a disease where I always say they have to know the components to drive their car, essentially. So there is not a full self-driving
Right.
automation loop for them. So they have to adjust and think about that. So when they go away from me or from my colleagues, they always can remind some sentences about, and as I knew it when I had fabulous physicians when I was 12, 13 years, I always reminded some sentences. And I'm speaking on a psychological basis now, but coming back to this, what did he told me? Insulin should be as low as possible, but it should be still enough, and such centerpieces of thinking, and therefore this is an important investment. But again, how to ultimately resolve this on a larger scale for the whole population, I cannot give you the final
Right,
answer.
right. Yeah, I think that will take some work. And you mentioned sort of like programs that might be more in a class setting, and that's something, of course, that and we've talked about that before. But so here in the US, we set up the this Renew program for kidney patients, which is kind of exactly like that. It's like actually a 3-month program. Patients meet with a dietitian once a week. They're also both in the class setting and also one-on-one. So, which I think works actually. It's almost like you mentioned learning to drive a car. It's interesting, anyone who needs to drive a car has to go to a driving school and learn
Yeah,
this, and it's many, many hours, and it goes over weeks and weeks. And the human body is a little more complicated than a car. So I totally see that, you can't just spend 10 minutes with a patient and expect them to drive, their own body after
yeah.
that.
Yeah, and it's also from when you have a patient who has 60-70% less kidney function and for 20 years diabetes, he's on a track of living 10-15 years less, having an awful quality of life. So if it would be in an oncology department, it would be different. You say you have cancer, wow, but this doesn't. There's still enough room in the human psyche. If I tell you, yeah, you have 1.5 creatinine, a little bit protein, you have a 20-fold increased risk of death. If you're on dialysis, you have the risk of a colon cancer to die. This is the statistic. We pay, at least in Austria, 70,000 euros per year, and 90% of the patients die before they come to dialysis. So only cynically the lucky ones go to dialysis. So this is something that I will not directly communicate because it doesn't have any success. But this is the reason why I have to want the patient in front of me, get out of all the pressure, and sitting there like a little dictator, and you have to obey me now. But I want to have him on board, that he has the responsibility now to take care for himself, and if he knows the rules, so to say, basic nature rules, there's a high chance of success that he will be simply living longer and be more happy.
Great. Good. And you mentioned early on the SGLT2 inhibitors, which are now, starting to get really widely used in diabetes and also kidney disease. And So, it's a good thing and a bad thing, I don't know. But the good thing is essentially what these drugs do is make you pee out all that glucose, right? So it's almost like a way of cheating. You can still eat a bad high carb diet and you essentially get rid of the problem later on. What has been your experience? So the mechanism is, very similar to what you do with dietary interventions, and in a sense, it's almost like if a patient, eats rat poison all the time, instinctively you would tell them stop eating rat poison. um, but with you could also say, oh, keep eating your rat poison and just take this antidote every day, which is a little bit like how these SGLT2 inhibitors kind of work, right? So you don't tell the patient to actually improve anything initially. You just tell them, oh, take this drug to pee out all that glucose again. So how do you mesh these things? Do you see value in using these drugs, maybe in addition or instead of dietary approaches, or how do you do it?
One has to say it was a by chance finding by the first study, the empiric study with empagliflozin, and it was some kind of a big dogma change, how we perceive things. This is also not so discussed a lot even today, because all the diabetes trials that have been done with pioglitazone or with various sulfonylureas or insulin combinations, simply bringing the patients into a very good metabolic state with regard to glycemia didn't result in any meaningful survival benefit, and even there were some harm signals. So dead in bed syndrome, higher mortality, and there were a lot of theories about that. Many argued, you used patients were used in the studies that were already sick and had a so-called legacy effect, so a memory of the damage of the glucose. And this was all wiped out with the empiric study because the FDA wanted, because of these previous studies, very diligent, solid analysis of cardiovascular endpoints, so that no harm could be arise, and there was a data safety monitoring board and all this kind of stuff. And by chance, it was found that there were less heart failure or less hospitalization due to heart failure, and progression of those certain part of patients that had already chronic kidney disease was halted, stopped. And they used the best therapy at this time, 2013, 14, 15. It was published initially at 15 and then 16 with the kidney data. So with RAS inhibitors, statins, as good as possible blood sugar control. And these patients had to have cardiovascular disease, so they were really sick. And you saw these tremendous effects. It was like often in medicine a by chance finding. And now there is this theory that, for example, not eating a lot of glucose with a low carb diet is some kind of mimicry of the SGLT2s. I'm not a fan of this theory. Why? We still do not know why SGLT2 inhibitors confer this tremendous effect, because you only have two side effects. This is via peeing out too much glucose. There are more fungal infections in about 2 to 3%. And patients, by and large, with normal kidney function can have the problem of ketoacidosis when they have not enough insulin secretion. So you don't see this in CKD patients and in all these heart failure patients. And it has become now the mainstay of heart failure therapy across the heart failure spectrum, with diastolic and systolic heart failure, and in chronic kidney disease, and with the same effect size whether you have diabetes or not diabetes. And what is going on? Obviously, there's some kind of alteration in the signaling parts of the kidney that lead to a different kind of perfusion of the glomeruli. And what we know now from a lot of very good and solid studies, even with biopsies of diabetic patients who are 16 years old and have overweight, there's an alteration in the mTOR pathway, and the tubuli are protected. So this is an extremely effective compound in retarding the progression of kidney disease, and we have the luxury, and I always have to stress that in chronic kidney disease, so if you have less than 50% kidney function, there is no more anti-diabetic effect because you do not pee out a lot of glucose, but you still have down to a GFR, like a percentage of 20 milliliters per minute, you have this nephroprotective effect. So, and this gave us also the chance to do our study, so go even lower towards a keto and a very low carb diet, and still using SGLT2s without having the danger of ketoacidosis in these advanced CKD patients. So I'm lucky that we have these kind of substances, and you have to use them strategically. Yeah.
Interesting, yeah. So don't SGLT2 inhibitors also raise ketone levels a little bit, not throughout the whole day, but probably during the overnight fasting period,
Yeah.
right?
They do this, but only if you have a normal kidney function.
Right.
So you don't see that. And there have been long speculations whether this mediates the heart failure protective effect because the heart muscle maybe then utilizes ketones, but it has been abandoned by and large. So this is not the mediator from the SGLT2s. Also, we see also in type 1 patients, they have ketones, but are not ketoacidotic. But they can enforce ketosis in these patients. Yeah.
Right, yeah. Okay, well, I think that there's more work to be done to figure out exactly what's going on there. My money is still on the ketones a little bit, because just like scientifically it makes a lot of sense that especially the beta hydroxybutyrate has, a lot of anti-inflammatory protective effects. But, great. So, good. So I'm really glad that there's someone like you starting to shout from the rooftops what you're seeing in your patients, and having lots of sort of a counterintuitive for most doctors. It seems like very counterintuitive, but it clearly works. What's next for you? Are there, you already talked a little bit about the, clinical studies you want to do. Are you planning any other trials? I know, we're planning to do something together as well. How does it look like in Austria? Maybe not only you, maybe like some of your colleagues, are they coming on board?
Yeah.
Yeah.
Yeah, so it's a fantastic movement now. So we have at the Medical University in Graz a group by Katrin Eller doing a lot of basic research, what is really going on in the kidney, also with regards to inflammation and immunology. We have Johannes Kovarik, who is now doing a lot of fantastic research. He was in the Jens Tietze lab, basically with skin sodium regulation by using high resolution 7 Tesla magnetic resonance. So what is really going on with regard to water conservation and salt regulation under ketosis? And he's also somehow an addict of the keto field, and seeing all the benefits that we see, and we really see, as I before mentioned, getting better blood pressure control. We do not exactly know what is really going on. We have some vague concepts. Maybe it's mediated via the loss of sodium or so, but we really don't know it at the end. And yes, we are doing now, where I'm very enthusiastic, also with your cooperation, studies in ADPKD. So we initially started to enroll several patients, and now it has become widespread, via social media, that in ADPKD it's potentially possible to have some effect or even have a full success by using ketones. And this is the reason why many patients now coming to our center, and we now have to try to manage how we will organize it to treat all these patients now, and also together with Sylvia, who is doing now her own PhD thesis on this topic with ADPKD and ketone bodies. And now we're interested in also advanced CKD patients with keto, and whether and how it works, whether when we use exogenous ketones and also simultaneously inducing endogenous ketosis on a nutritional basis.
Wow, yeah, a lot going on. That's really amazing.
Yeah, and it was of course, I want to say it was, of course, somehow fantastic that now the ADPKD story unfolds, because we have experience with ketosis now. What's going on with the uric acid levels? What's going on in advanced CKD with the bicarbonate serum levels and acidosis? We have to be afraid with 5.8 millimoles of beta hydroxybutyrate or not? And this is good that we have a lot of experience with that. And what we already see is the difference between ADPKD patients and type 2s, that they already come with a lot of experience that they have from the web. So they saw a lot of videos on diverse platforms, and they are extremely dedicated and determined. So I have young ones who are running half marathons and marathons and full ketosis with exogenous and endogenous ketones. So exciting times, what's going on in the next few years now on this level.
I totally agree. Yeah. Wonderful. Well, thank you, Markus. Maybe do you have any last thoughts? Anything we forgot to mention, or any message to patients or to your colleagues?
Maybe to my colleagues, this is a fantastic era that we have now, but I didn't realize, and I was reminded how science works, that now a lot of doors have been pushed open and we have to step in, because there are so many questions, and everybody who is dealing with ketones knows what's going on in the oncology field, in the neurology field, and we have so many questions to answer: how to apply it in the best mode, and what is, so to say, the dose, also in combination with different kinds of lifestyle. So for example, there evolved a program that we can maybe scale up, where we have 3 phases. So we tell the patients to get in deep ketosis when they have type 2 diabetes for a month. And then we look whether we can up-level the threshold. And we see then many land in between 60 to 80. So this is where we have the best success if we do not constantly do a remote monitoring of the patients. And this is also very compatible with most lifestyles. So it's very easy. We will tell them you are genetically somehow engineered from medieval times that you cannot adapt to 300 grams of carbohydrates. This is the reason why your ancestors survived. And here you are. You can buy now your ananas yogurt in December and your orange juice in February, but this is not normal. And most of them immediately say, yes, I understand you completely. Yeah. And yeah, a lot of new discoveries can be made. And if you're working directly with patients, it's one of the rare fields where you get immediate feedback. Immediate meaning in 1 or 2 months, when you use the right kind of also psychology. So don't look too much at body weight, focus on your well-being, and we will take care of the medical side. And then you can go deeper in this journey, and then you get an immediate reward by the patients. And yeah, this is maybe the roundup also for the scientific community. So just take it seriously, and you have to relearn a lot of how metabolism at the cellular level works. I also had to relearn with taking a lot of night shifts to understand what's really going on with fatty acid oxidation and diverse cycles of ketone body production. And if you go into this detail, you will find it fascinating, and you can translate it immediately to patients.
Wonderful. Great. That's really excellent. Where can people learn more? I know you have a YouTube channel, Marcus at Home, which is mostly in German, I think. And it's mostly geared towards practitioners, nephrologists, but so it's kind of like technical information, but any practitioner in the German-speaking, countries should probably, hopefully, be aware of it and tune in. So I think there's a lot of really interesting content there. We'll put a link down there, Marcus at Home. Is there anything anywhere else where people can learn more? Any social media or other ways of getting in touch with you? If somebody wants to see you, maybe they live in Austria, can they just drive up and knock on your door, get treated? Probably not.
Uh, I think I would be overwhelmed even if I once, but I only have a 24-hour day,
Right.
and yeah, I'm a little bit overcommitted. But if there are personal questions, I will try to answer. For example, every mail that will be sent to me. I don't have a specific homepage or something like that. Marcus at Home, by the way, is not the name is not after me because it's Marcus with K. It's because of my co-partner Gunnar Heine. He works at the Marcus Klinikum in Frankfurt. But nevertheless, it's very good for medical students and also patients and especially physicians dealing with heart and kidney internal medicine.
Great. Wonderful. Well, thank you, Marcus. I really appreciate your time going over all of this. You're doing, I think, just fantastic work there, and I think everyone should stay tuned for lots and lots of research and results coming out of Vienna. Great. Thank you, Marcus.
Yeah, thank you, Thomas. Thank you for the invitation, and also thank you for initiating all this ATP-KT adventure, where we are proud to be a part of that. And yes, as you told, I think the next 2, 3, 4 years will be very exciting, and also in the scientific world.
Yeah, I totally agree. Great. Super. Thank you, Marcus. Bye.
Goodbye.